Guys, welcome back to my channel MBPS Diaries. As we promised, today we are discussing about thyroid gland, and also we are covering two subject areas. First one is on the ciliate ganglion and the last one is thoracic outlet. And we will discuss in details about the topical areas and discuss about their clinical correlation. So let's begin with thyroid gland. And first, you have to understand some basic anatomy of thyroid gland. Thyroid gland is made up of two lobes. We see the right lobe, and the next we have the left lobe. And last, both lobes are connected by isthmus. See here, this one is right lobe, this one is left lobe, and both the lobes are connected by isthmus. Thyroid gland shape looks like a butterfly shape. Just remember this one. And there is another structure which is present, that is called recurrent laryngeal nerve. We will discuss this one in next slide. Now we discuss about the clinical relationship of thyroid gland with recurrent laryngeal nerve. Recurrent laryngeal nerve here travels in its respective tracheo-esophageal groove, and we can see the groove between trachea and esophagus, which lies posteriorly. This one is thyroid gland. This one is esophagus. Sorry, this one is trachea. And posterior to that, this is esophagus. And in between trachea and esophagus, there is a groove you can see here. And here you can find the recurrent laryngeal nerve, RLN in short form. This one is right and this one is left. In both the side we can find recurrent laryngeal nerve. This nerve is clinically important. During thyroidectomy, a surgeon has to carefully identify these nerves and preserve them so they are not to be injured during the removal of thyroid gland. Just note this point, clinically is important and surgeon has to be very careful to identify these nerves for the removal of thyroid gland or something like tumor or cancer. Now, here are some of the important aspects of recurrent laryngeal nerve. Recurrent laryngeal nerve is a branch of vagus nerve, supplies all the intrinsic laryngeal muscle with an exception of cricothyroid only. This one is an exception. The left recurrent laryngeal nerve and the right recurrent laryngeal nerve have some anatomical difference. Left recurrent laryngeal nerve loops under the aortic arch, whereas right recurrent laryngeal nerve loops under right subclavian artery. And recurrent laryngeal nerve comes from the vagus nerve and travels back upward either side of trachea or larynx. This point you have to memorize. And just for the information, you have to remember this also. Now next, we have to memorize all the blood supply of thyroid gland. These are all blood supply. Just you have to memorize those names. Next, we're coming to the nerves. These all are the nerve supply to of thyroid gland, like superior medial, inferior cervical ganglion, sympathetic group, and the parasympathetic groups are vagus and recurrent laryngeal nerve, which have two, that is called left recurrent laryngeal nerve and the right one. Now we are discussing about the symptoms of goiter. First one, it's coughing. Due to its very large mass, it can affect on the respiratory passageway and the larynx. As you can see here, if it's larynx and some other passageway here, and due to its huge mass, it can give force to the passageway and it creates an irritation and coughing occurs, or it can create difficulty in breathing also here, this point and this point. Now coming to our next symptom, that is hoarseness. A very large goiter can involve the nerve, that is recurrent laryngeal nerve, in both sides, and if they become involved, they are unable to effectively activate the muscles of the larynx and create hoarseness. It is only because it affects this nerve and there is difficulty in muscles contraction, so hoarseness occurs. Now the third symptom is dysplasia. Its definition is it's have to be like difficulty in swallowing, as you can easily understand, due to its large mass effect. It creates a pressure here and the food canal becomes narrow, and suppose if food enters into the mouth, when enters into the food canal, it creates difficulty and some irritation occurs in the food canal. And the last, and that is difficulty in breathing, as I said to earlier. We are discussing about an interesting topic, that how to understand that it is functional nodules or non-functional nodules. So by using technetium 99M, please cut this M, it's an additional one. It's called technetium 99M per tectinet scan. We can see hot nodules and cold nodules. As you can see here in picture, this one is hot nodules and this one is cold nodule. So how you can understand this is hot or cold? In hot nodules, you can see there is an yellow color. This color is due to presence of functional nodules. As they pick up the technetium 99M, so the area is lighten up, this area. And another side, the cold nodules, which is non-functional nodule, it didn't pick up that 99M technetium and it's in pink color. Now here is some aspect of cold nodule. It is non-functional, first of all, usually benign, and third one, odds to benign, malignant, and greater than hot nodules. Just point to be remember, nothing else. Now we are moving into our clinical part, that is on the thyroid ectomy. Some of the indications of thyroidectomy is goiter, first one. Second one is right here in the screen. First indication, goiter. Second one is cancer in thyroid gland. And third one is hyperthyroidism. Some complications associated with thyroid gland in thyroidectomy include bleeding. Bleeding happens sometimes. Infection, hoarseness due to the damage of recardial laryngeal nerve in both sides. Remember, it has right one, and the left one. And last one, that is hyperthyroidism. Now moving to our next topic, that is on ciliate ganglion block. First, we have to understand its anatomy. Then we are going through its importance and so on. First, we have to identify where ciliate ganglion is present. It is present here. Okay. And another important structure that you have to know, that is carotid tubercle. It is present here. Now we have to know about its anatomical location of ciliate ganglion. It is located anterior to transverse process of vertebra number 7. I mean cervical vertebra now number 7, and we have to know about the carotid tubercle location, that is on the anterior tubercle of cervical vertebra number 6. Now this carotid tubercle, which is present here, has an important landmark. It is an important landmark in the performance of ciliate ganglion. Actually, physician used to give the injection to this landmark, which is superior to ciliate ganglion, so that nerve blocking agent will diffuse inferiorly and have its influence or its effectiveness at the level of ciliate ganglion. And the ciliate ganglion is here. It has an also anatomical relationship in the area of the neck. If you think about this area of the neck, I mean from here to here, you can easily find common carotid artery, intrajugular vein, and brachial plexus, which will help you in clinical subject or help the physicians to having its approach in surgery. So let's move to the relevant anatomy of ciliate ganglion block. Just remember, not the ciliate ganglion, it's a ciliate ganglion block, and how it's used for the block, why one should perform the ciliate ganglion block. So we're looking at the indications. First one, that is complex regional pain syndrome. First, this can be performed to treat individuals that have complex regional pain syndrome. This will then meet to the afferent that are coming from the periphery towards the spinal cord. And next one, that is hyperhidrosis. It can be also treated to inhibit excessive sweating or hyperhidrosis. Please recall the sympathetic stimulation of the sweat gland, so blocking is useful here. Next, it is used to treat vascular insufficiency. Next one is it is used to perform to treat refractory angina, and last one to treat the persons having amputation of either upper limb or limb pain. Now coming to our last part, that is on thoracic outlet. Let's talk about its boundaries. First one is manubrium. We'll look at the picture so that you can understand. This one is manubrium. I am using blue color for manubrium. And second one is first rib, which is present in both side. So that's why it's bilateral. Sorry, bilaterally in. And third one is first thoracic vertebra, that is here. I am using green color to identify it. And this one is manubrium. Now, in this thoracic outlet, we have a muscle called scaled muscle, and its triangle is called interscalene triangle. Its boundaries are actually is bounded by anterior scalene muscle. Here I am using white color to identify it. This muscle, which is attaching to first rib here inferiorly. Next one, medial scalene muscle, that is here. I am using green color just beside of that, which is also attaching to first rib here. This one is middle scalene and this one is anterior scalene muscle. Sorry, using white. Yes. And the third one is first rib. Third boundary is first rib. It is at the base of the triangle between anterior scalene muscle and the middle scalene muscle. Now let's see, a triangle is forming here and it's bounded by these three. That's why it's called interscalene triangle. Now interscalene triangle contains brachial plexus. Here you can see the brachial plexus in yellow here. It's all brachial plexus trunks. Now we are moving to the next content of interscalene triangle, that is subclavian artery here. These both are inside the triangle. But this subclavian vein, which is here, which is not inside the triangle. Just remember it. Sorry. Triangle. Thanks for watching. Please subscribe and like to my channel.